measurement of doses can be done. So the next topic is unlocking the angle, gonioscopy techniques for clinicians by Dr. Leema Rose Thomas.
Good morning, everybody. Let me thank Sija and KSOS for this opportunity. My topic is gonioscopy techniques for clinicians. Now, it's a clinical technique to visualize the anterior chamber angle. Because of the projecting shelf of the sclera and total internal reflection, we can't see the angle, and therefore we use a medium which changes the critical angle, and thereby you can visualize the angle. It's essential for glaucoma diagnosis and management. So what are the indications? In glaucoma evaluation, we need to diagnose the type of glaucoma, whether it's open, closed, primary, secondary. You also need to assess the angle closure risk. For treatment, we need to use different lenses, whether you're doing a laser surgery like SLT, or you're doing something like the surgeries, that is goniotomy and all that. For pediatric, you need lenses. Then monitoring the treatment efficiency. You've sent the patient for a PI, you've done it, and then your efficiency of the PI and whether the angles have opened, you will check with that. And you also needed to evaluate specific types of glaucoma like primary congenital glaucoma, pigment dispersion glaucoma, and pseudoexfoliation syndrome. Now, other ocular conditions where gonioscopy is of help is in trauma assessment. In trauma, you look for angle recession, iris disinsertion, foreign bodies, or other damage following eye traumas. And you also use to look for NVAs, identifying tumors or masked lesions, and you look for signs of past or active inflammations. And in congenital and acquired anomalies like the Axenfeld-Rieger syndrome, in the congenital glaucomas, aniridia, all those things, gonioscopy becomes a very important part of the examination. Now, gonio lenses are the commonest using ones, the indirect ones. The Goldman gonio lenses is one type of lenses. We have the single mirror, double mirror, and the three mirror, which is a multi system disciplinary. This thing we use for retina and glaucoma. We also have the C's in the Posner and the Sussman, which are the 4-mirror lenses, which are different and can be used for indentation gonioscopy. Now, these are the Sussman and this thing. Now, direct gonio lenses are Copy lens, Barkin lens, and Swan-Jacob lenses, usually used where the patient is not able to be at the slit lamp and for surgeries. Now, anatomy of the angle of the anterior chamber from posterior to the anterior is the iris root, ciliary body band, scleral spur, trabecular meshwork, and the Shalby's line. So, the mnemonic is I can see the line. So, preparation, how do you prepare? So, you have to explain to the patient what is the procedure. A topical anesthesia is used. Patients positioned properly on the slit lamp with the chin in the right place and the head touching the headband. Then lens is prepared. For example, if you're using a lens with Goldman lens, the important part of it is the filling of the coupling agent, because you should fill it properly, you should fill it without any air bubble. So that is very important. And then as far as the 4-mirror lenses is concerned, you don't need the coupling fluid. Then room lighting, the ambient room light has to be dimmed to make sure that the angle is not getting opened up because of pupillary constriction. Now, procedure, first one is the lens insertion. The patient is asked to look down, look up, and then you keep the gonio lens on the sclera, making sure that you don't spill the viscoelastic, and keep it. Ask the patient to look straight, and it gets into the position. In gonio, in the 4-mirror lenses, you just ask the patient to look forward and keep it on the center of the cornea. Now, angle examination, you focus on the angle. Usually the inferior and the angle is looked, which is a superior mirror, and you focus on this thing to look at the different things. A systematic examination is required, and as you know, when you look at the each angle is looked for. For the Goldman, if it is a single or a 2-mirror, you might have to rotate the lenses. For the 4 mirrors, you just have to adjust the slit lamp to illuminate the mirror or the angle that you're looking for. And when you're looking at the nasal and the temporal mirrors, it's always ideal to keep it perpendicular to the angle. Turn the slit lamp beam to make it this thing. Every time you should make sure that your light is not on the pupil. It should be smaller than that, because you don't want a pupillary constriction. So angle is examined after the initial examination, where you determine whether it's an occludable angle or not, which is the non-visualization of the trabecular meshwork. Then actually you can increase the width of the light, because you want the pupil to now constrict and give you a more visualization into the angle, so that any other abnormal angle structures can be seen. So it can be visualized properly. So that is done. Now coming to manipulative and intubation gonioscopy, and you have to do the documentation. So lens removal lens is gently removed by asking the patient to look down and slightly ask the patient to look up later. Clean up any excess coupling fluid can be wiped away or irrigated with saline solution if desired. Patient instruction: patient is advised not to rub their eyes for about 20 minutes while the anesthetic wears off. Now, dynamic or indentation gonioscopy. In the cases of small diameter base like Cs, you actually press the center of the cornea, and which would push the aqueous into the periphery and therefore will widen the angle. So if there is a if the closure was appositional, you will get a opening of the angle, and if the closure is cynical, it doesn't open. So you differentiate between that. The same thing can be done in a manipulative gonioscopy as well as a Goldman is concerned, where pressing the will close the angle because the flange is at the limbus. There you ask the patient to look at the mirror that you're examining, which will open up the angle. Now documentation is very important. You have to document the posterior most structure that you're seeing. Outside the ring, you write the amount of trabecular pigmentation, and outside that you record what are the abnormal things that you see, like a PAS or angle recession or anything. And the AAO talks about a Becker's goniogram, which is like you write all the lines, and there is color coding for the different pathologies like blood, for NVAs, pigments, angle recession, etc. And gonioscopy grading system, the most common use is definitely the Schafer's. It is depending upon the angular width of the angle and the most posterior structure that is visible. Where the higher the number, it is a wider the angle. And Chi system is the other way around. It uses Roman letters, and the higher number signifies a narrower angle. A more comprehensive checkup is the Spade gonioscopy grading system, where it is one is the insertion of the iris root, and it's the grading from A to E, depending on where the iris is inserted. Then the angular, you look at the angle width. You also look for the peripheral iris configuration, depending on whether it's cure, that is concave, or regular or flat. And also you look for the pigmentation. So you grade it from 0 to 4. Now, obviously, the differentiation is between a wide and a narrow angle, and the structure that is PTM, that is a pigmented trabecular meshwork. If you're not seeing the PTM without any manipulation, without any indentation, for more than 180 degrees, then it is considered to be an occludable angle. Common abnormal findings would include PAS, blood, pigmentation, neovascularization, etc. So this is a finding, that is a pigment dispersion syndrome, where you see the sample disease line, which is a pigment dispersion line, and a uniformly pigmented trabecular meshwork. You see a peripheral anterior synechiae, which is not open even on indentation. Then in Axenfeld-Rieger syndrome, what you see is the posterior embryotoxin, which is a thickened Schwalbe's line. You also see numerous iris processes and PAS. Now in NVA, you see these radial filiform blood vessels, which you're seeing in this thing. In a post-trab, you can look for the health of the ostium, whether the ostium is open and whether something has clogged the ostium. And also in trauma, you should look for the cyclodialysis cleft. Angle recession is the irregular widening of the ciliary body band. And blood in Schlemm's canal is an important finding in secondary glaucomas due to increased episcleral venous pressure. But on prolonged gonioscopy using a Goldman mirror, also it can produce a blood in Schlemm's canal. So gonioscopy is essential for glaucoma workup and maybe many other pathologies in the eye. Proper technique improves the accuracy. Practice is key. Thank you so much for your patient listening.